Dear students, welcome to the second online lecture of clinical pharmacy. This is your course lecturer, Yasser Abbasi. I hope you have got the course outline and you have gone through the orientation in first lecture. In this lecture we will review different definitions and terminologies used in clinical pharmacy. We will also compare pharmacy and pharmacist with different healthcare professionals in terms of their job description. Before we move on to different definitions, let's have an overview of the history and see how clinical pharmacy have evolved. The emergence of clinical pharmacy as a form of professional practice has been attributed to the poor medicines control systems that existed in hospitals during the early 1960s. Although provoked by similar hospital-associated problems, the nature of the professional response differed between the USA and the UK. In the USA the approach was to adopt unit dose dispensing and pursue decentralization of pharmacy services. In the UK the unification of the prescription and the administration record meant this document needed to remain on the hospital ward and required the pharmacist to visit the ward to order medicines. Clinical pharmacy developed from the presence of pharmacists in these patient areas and their interest in promoting safer medicines use. This was initially termed ward pharmacy, but participation in medical ward rounds in the late 1970s signaled the transition to clinical pharmacy. Clinical pharmacy in the 1980s grew because of its ability to promote the cost-effective use of medicines in hospitals. This role was recognized by the government, which in 1988 endorsed the implementation of clinical pharmacy services to secure value for money from medicines. Awareness that support depended to an extent on the quantification of actions and cost savings led several groups to develop ways of measuring pharmacists' clinical interventions. The year 1979 was a pivotal year in international clinical pharmacy. That year, both the American College of Clinical Pharmacy, ACCP, and the European Society of Clinical Pharmacy, that is, ESCP, were formed. These organizations were created by pioneering clinical pharmacists. These organizations specifically represented and promoted clinical pharmacy. American Society of Health System Pharmacist, USHP, rolled out new residency accreditation standards in 1980. These standards were divided into accreditation for clinical pharmacy practice and specialty pharmacy practice, which began the first formal accreditation of unique practice areas in pharmacy. These specialty areas included internal medicine, critical care, infectious diseases, primary care and many others. In February 1985, ASHP organized an invitational conference in South Carolina. The attendees provided a broad representation in pharmacy and they articulated that pharmacy was a clinical profession. This and other important pharmacy leadership conferences energized the profession of pharmacy to further spark the growth of clinical pharmacy in the US during the 1980s. Literally hundreds of papers and studies appeared in the literature that documented the value of clinical pharmacy services in hospitals and ambulatory settings. Many clinical pharmacists were beginning to focus their practices and specialize in unique areas such as cardiology, emergency medicine, oncology, infectious diseases, critical care, primary care and many others. These developments necessitated specialty training, and many papers were describing the new areas of specialty forming in pharmacy. Some criticized that clinical pharmacy is a service that provides much of the time directly to physicians and less focus on patients. These criticisms led to important concepts of pharmaceutical care. The pharmaceutical care was introduced as a covenantal relationship between the pharmacist and the patient, in which the pharmacist's primary responsibility was to identify, prevent and resolve drug-related problems. This concept articulated the responsibility of the pharmacist to work directly with the patient to optimize drug therapy. Pharmaceutical care was eventually adopted around the world. The issue of the proper degree in pharmacy had been debated in the US since at least the 1930s. There were two early developments that shaped clinical pharmacy, including the formation of Doctor of Pharmacy degree, Pharm. D. programs and residencies in clinical pharmacy. While there were earlier attempts to provide the Pharm. D. degree, it was first formally recommended in 1950. However, only the University of Southern California implemented the Pharm. D. in 1950, and then the University of California San Francisco followed in 1955. A few other colleges of pharmacy adopted the degree in the late 1960s. In 1992, the AACP House of Delegates voted to approve the Pharm. D. degree as the only professional degree in pharmacy, doing away with the Bachelor of Science in Pharmacy. The American Council on Pharmaceutical Education, a CPE, is the body that sets educational standards and accredits colleges of pharmacy. In 1997, ICPE decreed that they would no longer accredit Bachelor of Science programs effective in 2000, and all colleges of pharmacy had to convert to the Pharm. D. as the sole professional degree. The developed world now see future role of pharmacist in direct patient care. It is becoming clear that some types of clinical pharmacy practices have to manage very complex patients. In order to provide direct patient care through pharmacists, the U.S. is preparing certified specialists in clinical pharmacy. For instance, there were nearly 4,000 board-certified specialists in clinical pharmacy in 2003. By 2014, these numbers had increased to almost 22,000. The table in this slide displays the various clinical pharmacy specialties in the U.S., the year the specialty was approved by the Board of Pharmaceutical Specialties, and the number of individuals certified in each specialty in 2012 and 2014. These dramatic increases in highly trained specialists have positioned the profession of pharmacy extremely well for the major changes that have occurred in healthcare reform. Up till now we have seen that the Pharm. D program in the United States is the epitome of the practice-based model, as it evolved from industrial and compounding pharmacy to a more patient-focused program. Now, what about Pakistan? The pharmacy program in Pakistan was initiated as a 3-year baccalaureate program, and then, in 1978 to 1979, it was lengthened to a 4-year program. At that time, The pharmacy curriculum was directed mainly towards the production of pharmaceuticals, which helped provide the pharmaceutical industry with well-qualified and skilled human resources, but there was no consideration of the public health role of the pharmacist. Hence, in Pakistan, the Pharm D degree was introduced as the basic degree in pharmacy in 2004, replacing the 4-year traditional Bachelor of Pharmacy (B Pharm) degree. As we have discussed, that Pharm D degree, even in US, took years to fully develop. It might not be surprising that, when analyzed closely in Pakistan, it was still in a transitional form from an industrial program to a clinical, patient-focused care program. The pharmacy practice has been recently introduced as 5th department of this program. The American College of Clinical Pharmacy's 10 to 15-year vision for the profession is that pharmacists will be healthcare providers who are accountable for optimal medication therapy in the prevention and treatment of disease. To achieve this vision, the profession must ensure that there will be an adequate supply of appropriately educated and skilled clinical pharmacists. Toward that end, the ACCP has developed a definition of clinical pharmacy to serve as the foundation for the core competencies of a clinical pharmacist. Both short, abridged, and detailed, unabridged, definitions are given. The abridged definition of clinical pharmacy defines it as that area of pharmacy concerned with the science and practice of rational medication use. The unabridged definition of clinical pharmacy is very long. Here I have only kept first paragraph of detailed definition. The complete unabridged definition has been attached as a file in HULMS. I would recommend you to pause this video, read the complete definition from handout first and then replay this video lecture. The first para of detailed definition of clinical pharmacy states that clinical pharmacy is a health science discipline in which pharmacists provide patient care that optimizes medication therapy and promotes health, wellness, and disease prevention. The practice of clinical pharmacy embraces the philosophy of pharmaceutical care. It blends a caring orientation with specialized therapeutic knowledge, experience, and judgment for the purpose of ensuring optimal patient outcomes. As a discipline, clinical pharmacy also has an obligation to contribute to the generation of new knowledge that advances health and quality of life. From the unabridged definition of clinical pharmacy, we will now define some other terms which we have come through during the introduction of clinical pharmacy. The pharmaceutical care is the direct, responsible provision of medication-related care for the purpose of achieving definite outcomes that improve a patient's quality of life. Many pharmacists have expressed enthusiasm for the concept of pharmaceutical care, but there has been substantial inconsistency in its description. Some have characterized it as merely a new name for clinical pharmacy, others have described it as anything that pharmacists do that may lead to beneficial results for patients. American Society of Health System Pharmacists, ASHP, believes that pharmaceutical care is an important new concept that represents growth in the profession beyond clinical pharmacy as often practiced and beyond other activities of pharmacists, including medication preparation and dispensing. All of these professional activities are important, however, and ASHP continues to be a strong advocate of the necessity for pharmacists' involvement in them. In practice, these activities should be integrated with and culminate in pharmaceutical care provided by individual pharmacists to individual patients. The principal elements of pharmaceutical care are that it is medication-related, it is care that is directly provided to the patient, it is provided to produce definite outcomes. These outcomes are intended to improve the patient's quality of life, and the provider accepts personal responsibility for the outcomes. The definite outcome means that our knowledge-based decisions results in known outcomes for the patients and do not put them on trial and error like risks. By medical-related we mean that pharmaceutical care involves not only medication therapy, the actual provision of medication, but also decisions about medication use for individual patients. As appropriate, this includes decisions not to use medication therapy as well as judgments about medication selection, dosages, routes and methods of administration, medication therapy monitoring, and the provision of medication-related information and counseling to individual patients. Central to the concept of care is caring, a personal concern for the well-being of another person. Overall patient care consists of integrated domains of care including, among others, medical care, nursing care, and pharmaceutical care. Health professionals in each of these disciplines possess unique expertise and must cooperate in the patient's overall care. At times, they share in the execution of the various types of care, including pharmaceutical care. To pharmaceutical care, however, the pharmacist contributes unique knowledge and skills to ensure optimal outcomes from the use of medications. At the heart of any type of patient care, there exists a one-to-one relationship between a caregiver and a patient. In pharmaceutical care, the irreducible unit of care is one pharmacist in a direct professional relationship with one patient. In this relationship, the pharmacist provides care directly to the patient and for the benefit of the patient. The health and well-being of the patient are paramount. The pharmacist makes a direct, personal, caring commitment to the individual patient and acts in the patient's best interest. The pharmacist cooperates directly with other professionals and the patient in designing, implementing, and monitoring a therapeutic plan intended to produce definite therapeutic outcomes that improve the patient's quality of life. Some tools exist now for assessing a patient's quality of life. These tools are still evolving, and pharmacists should maintain familiarity with the literature on this subject. A complete assessment of a patient's quality of life should include both objective and subjective, for example, the patient's own assessments. Patients should be involved, in an informed way, in establishing quality of life goals for their therapies. The fundamental relationship in any type of patient care is a mutually beneficial exchange in which the patient grants authority to the provider and the provider gives competence and commitment to the patient, that is, accepts responsibility. Responsibility involves both moral trustworthiness and accountability. In pharmaceutical care, the direct relationship between an individual pharmacist and an individual patient is that of a professional agreement in which the patient's safety and well-being are entrusted to the pharmacist, who commits to honoring that trust through competent professional actions that are in the patient's best interest. As an accountable member of the healthcare team, the pharmacist must document the care provided. The pharmacist is personally accountable for patient outcomes, the quality of care that ensue from the pharmacist's actions and decisions. It is the goal of pharmaceutical care to improve an individual patient's quality of life through achievement of definite, that is predefined, medication-related therapeutic outcomes. The outcomes sought are, cure of a patient's disease, for example, complete elimination of bacterial infection, elimination or reduction of a patient's symptomatology, for example, reduction in pain from cancer, arresting or slowing of a disease process, for example, rheumatoid arthritis, HIV infection, and prevention of a disease symptomatology, for example, coronary heart diseases, heart attack, and stroke. This, in turn, involves three major functions: 1. Identifying potential and actual medication-related problems, 2. Resolving actual medication-related problems, and 3. Preventing potential medication-related problems. A medication-related problem is an event or circumstance involving medication therapy that actually or potentially interferes with an optimum outcome for a specific patient. There are at least these categories of medication-related problems. Untreated indications: the patient has a medical problem that requires medication therapy, an indication for medication use, but is not receiving a medication for that indication. Improper drug selection: the patient has a medication indication but is taking the wrong medication. Subtherapeutic dosage: the patient has a medical problem that is being treated with too little of the correct medication. Failure to receive medication: the patient has a medical problem that is the result of not receiving a medication, for example, for pharmaceutical, psychological, sociological, or economic reasons. Overdosage: the patient has a medical problem that is being treated with too much of the correct medication, that is, the toxicity. Adverse drug reactions: the patient has a medical problem that is the result of an adverse drug reaction or adverse effect. Drug interactions: the patient has a medical problem that is the result of a drug-drug, drug-food, or drug laboratory test interaction. Medication use without indication: the patient is taking a medication for no medically valid indication. Patients may possess characteristics that interfere with the achievement of desired therapeutic outcomes. Patients may be non-compliant with prescribed medication use regimens, or there may be unpredictable variations in patients' biological responses. Thus, in an imperfect world, intended outcomes from medication-related therapy are not always achievable. Patients bear a responsibility to help achieve the desired outcomes by engaging in behaviors that will contribute to, and not interfere with, the achievement of desired outcomes. Pharmacists and other health professionals have an obligation to educate patients about behaviors that will contribute to achieving desired outcomes. Pharmacists use a patient-centered approach in collaboration with other providers on the healthcare team to optimize patient health and medication outcomes. An essential first step is the establishment of a patient-pharmacist relationship that supports engagement and effective communication with patients, families, and caregivers throughout the process. In addition, at the core of the process, pharmacists continually collaborate, document, and communicate with physicians, other pharmacists, and other healthcare professionals in the provision of safe, effective, and coordinated care. This process is enhanced through the use of interoperable information technology systems that facilitate efficient and effective communication among all individuals involved in patient care. In pharmaceutical care process, the first step is to collect. The pharmacist assures the collection of necessary subjective and objective information about the patient in order to understand the relevant medical, medication history and clinical status of the patient. Information may be gathered and verified from multiple sources including existing patient records, the patient, and other healthcare professionals. This process includes collecting a current medication list and medication use history for prescription and non-prescription medications, herbal products, and other dietary supplements. Relevant health data that may include medical history, health and wellness information, and physical assessment findings. And patient lifestyle habits, preferences and beliefs, health and functional goals, and socioeconomic factors that affect access to medications and other aspects of care. The next step is to the information collected and analyzes the clinical effects of the patient's therapy in the context of the patient's overall health goals in order to identify and prioritize problems and achieve optimal care. This process includes assessing each medication for appropriateness, effectiveness, safety, and patient adherence, health and functional status, risk factors, health data, cultural factors, health literacy, and access to medications or other aspects of care, immunization status and the need for preventive care and other healthcare services, where appropriate. Then, the pharmacist develops an individualized patient-centered care plan, in collaboration with other healthcare professionals and the patient or caregiver that is evidence-based and cost-effective. This process includes establishing a care plan that addresses medication-related problems and optimizes medication therapy, sets goals of therapy for achieving clinical outcomes in the context of the patient's overall healthcare goals and access to care, and engages the patient through education, empowerment, and self-management. Once the plan is ready, the pharmacist implements the care plan in collaboration with other healthcare professionals and the patient or caregiver. During the process of implementing the care plan, the pharmacist addresses medication and health-related problems and engages in preventive care strategies, including vaccine administration, initiates, modifies, discontinues, or administers medication therapy as authorized, provides education and self-management training to the patient or caregiver, contributes to coordination of care, including the referral or transition of the patient to another healthcare professional, schedules follow-up care as needed to achieve goals of therapy. After implementation of the plan, the pharmacist monitors and evaluates the effectiveness of the care plan and modifies the plan in collaboration with other healthcare professionals and the patient or caregiver as needed. This process includes the continuous monitoring and evaluation of medication appropriateness, effectiveness, and safety and patient adherence through available health data, biometric test results, and patient feedback, clinical endpoints that contribute to the patient's overall health and outcomes of care, including progress toward or the achievement of goals of therapy. In a nutshell, the pharmaceutical care process is to identify, resolve, prevent, and monitor medication-related problems. In our upcoming lectures, we might have some case studies in order to further understand the pharmaceutical care process. Now we will study that what is medicines optimization. Let's review some data about adherence with medications. Some studies from UK show that only 16% of patients who are prescribed a new medicine take it as prescribed, experience no problems and receive as much information as they need. It means that a larger proportion of patients do not take medications as they are prescribed or they experience some problems. 10 days after starting a medicine, almost a third of patients are already non-adherent. Of these, 55% don't realize they are not taking their medicines correctly, whilst 45% are intentionally non-adherent. We know that non-adherence means not to follow the instructions of prescriber or not take the prescribed medications or discontinue the medicines without instructions of the prescriber. A study conducted in care homes found that over 2/3 of residents were exposed to one or more medication errors. In primary care, around £300 million per year of medicines are wasted. This is likely to be a conservative estimate, of which £150 million is avoidable. And at least 6% of emergency readmissions are caused by avoidable adverse reactions to medicines. This data suggests the need of an approach to improve the outcomes of therapy. Therefore, medicines optimization is about ensuring that the right patients get the right choice of medicine, at the right time. By focusing on patients and their experiences, the goal is to help patients to improve their outcomes, take their medicines correctly, avoid taking unnecessary medicines, reduce wastage of medicines, and improve medicines safety. Ultimately, medicines optimization can help encourage patients to take ownership of their treatment. The medicines optimization approach requires multidisciplinary team working. Healthcare professionals need to work together to individualize care, monitor outcomes more carefully, review medicines more frequently and support patients when needed. Medicines optimization differs from medicines management in a number of ways, but most importantly it focuses on outcomes and patients rather than process and systems. Based on the discussions up till now, we can conclude that, in order to provide patient care, a clinical pharmacist is integration of these knowledge and skills. I am confident that you will learn to acquire all of these knowledge by the completion of advanced clinical pharmacy in your final semester. Medication therapy management, MTM, is another important term in clinical pharmacy. This is defined as a range of services provided to individual patients to optimize therapeutic outcomes and detect and prevent costly medication problems. MTM provided by pharmacists include a review of all medications prescribed by all prescribers providing care to the patient, and any over-the-counter and herbal products the patient may be taking to identify and address medication problems. Problems may include all of the problems that we have listed in previous slides. In-depth, medication-related education, consultation, and advice provided to patients, family and/or caregivers to help assure proper use of medications, or collaboration with the patient, physician, and other healthcare providers to develop and achieve optimal goals of medication therapy. The MTM service model in pharmacy practice includes these 5 core elements. These 5 core elements form a framework for the delivery of MTM services in pharmacy practice. Every core element is integral to the provision of MTM, however, the sequence and delivery of the core elements may be modified to meet an individual patient's needs. Each element itself requires a separate discussion. In this lecture, however, we will only review each element briefly. The medication therapy review is a systematic process of collecting patient-specific information, assessing medication therapies to identify medication-related problems, developing a prioritized list of medication-related problems, and creating a plan to resolve them. The personal medication record is a comprehensive record of the patient's medications, that is, prescription and non-prescription medications, herbal products, and other dietary supplements. The medication-related action plan is a patient-centric document containing a list of actions for the patient to use in tracking progress for self-management. In intervention and/or referral, the pharmacist provides consultative services and intervenes to address medication-related problems. When necessary, the pharmacist refers the patient to a physician or other healthcare professional. MTM services are documented in a consistent manner, and a follow-up MTM visit is scheduled based on the patient's medication-related needs, or the patient is transitioned from one care setting to another. If you have noticed, the MTM is actually another term for pharmaceutical care process. This slide lists the clinical pharmacy services. Many of these have discussed in previous slides. I assume you won't have any difficulty with any other listed service. If you have, we can discuss it in our upcoming live sessions, or you can let me know on my email address. We have reached to last section of this lecture, where we will compare clinical pharmacist with other pharmacist in terms of their job responsibilities. There are many different types of pharmacy, and other places where a trained pharmacist may work. Most of these are given in this slide, however, there are various other specializations in the field of pharmacy as well. I would allow some time here so that you can view the job functions of different pharmacists. you must have noticed that the role of a clinical pharmacist is directly involved in patient care process. The aim of clinical pharmacy is to ensure the optimal use of medications for the best outcomes through the provision of drug information and monitoring for drug safety and efficacy. Furthermore, clinical pharmacist is involved in teaching, administrative functions in the selection, proper storage, distribution and prescription protocols of drugs, education of medical staff in the aspects of selection, administration and monitoring of drug safety. Please note again, that this is the direct interaction of clinical pharmacist with patients that differentiate him or her from other pharmacists. I would again take a pause here, so you can quickly take a view of brief job descriptions of healthcare professions. In this comparison you can see that when it comes about comparison of clinical pharmacist with other healthcare professions, the clinical pharmacist is regarded as a sole expert of drugs. Therefore, clinical pharmacist is an important member of healthcare team. We can summarize this lecture as, the profession of clinical pharmacy is directed towards patients. It involves identification, rectification, and then follow-up of medication-related problems through pharmaceutical care process or MTM. The soft copy of these slides have been uploaded on Hamdard University's Learning Management System. You should refer to first chapter of Roger Walker's Clinical Pharmacy and Therapeutics. The sources of the definitions covered in this lecture would also be available on HULMS. If you wish to download this video, get the link from portal. We complete our second lecture here. Got any queries? Direct them to my email. Stay safe and blessed. Allah Hafiz.